Okay, welcome everybody. I'm Rebecca Griffith, the EDDPT, one of many amazing EDDPTs around the planet, and I am really excited to have our second journal club today. If you weren't able to join us in person, I really appreciate you watching this replay later. And I'm very excited to introduce Dr. Keith Roper, who is one of the authors with our article tonight, which is Dedicated Emergency Department Physical Therapy is Associated with Reduced Imaging, Opioid Administration, and Length of Stay, a prospective observational study. Thanks, Keith.
And that's a mouthful of a title, isn't it? Thanks for
sure.
Yeah, thanks for inviting me.
Do you want to give everybody a little background about yourself?
So I am a physical therapist. I've been practicing for over 30 years. I spent most of my career in rural Northern California, where I owned a private practice for all that time and kind of saw a little bit of everything. I was a kind of a one-man guy out in the middle of nowhere, really. I came to Utah about 6 years ago, and shortly after I came here, had the invitation to start working in an emergency department. Started part-time and fairly rapidly ramped up to full-time. I was there for a little over 3 years. And so this study that we're going to look at tonight actually covers about the first 18 months, I believe, of when I was there in emergency. And then when COVID happened, one of the things that changed was I got kicked out of emergency for a while. And so I'm actually just going back next month. I'm starting to go back part-time, and by December I'll be back in pretty close to full-time. So really looking forward to being back there, and I've enjoyed my time working in emergency so far.
If anybody is interested in hearing more about Dr. Roper, I was lucky enough to be able to interview him last week, so you can hear more about how he got from rural outpatient practice to the emergency department in a large academic medical center. I just would love if the rest of you wouldn't mind introducing yourselves. Isla, go ahead. It's so nice to have you.
Hi, my name is Isla. I'm a PT student actually in Miami. And I just heard of Rebecca and saw her on Instagram and was curious in regards to the ED and PT. I heard of us in the ED in my first term. I just finished my first year. So this is really interesting and exciting for me.
That's awesome. Can I ask what kind of course content that was?
It was just an introduction. So it was physical therapy practice. We were just going over little things of where we practice, and it came out, and I went and asked her about it, and she said, yeah, I did a little bit. And then I was like, oh, okay, that's pretty cool. And then I found you on Instagram, and I was like, oh yes, this is great.
Love it. Kyle, are you able to introduce yourself?
That wasn't rough. Yeah.
I'm Kyle Moth. Oh, hey, physical therapist, Madison, Wisconsin, work in emergency department. Yeah, and I was there today. That's why I'm home eating dinner right now. Thanks.
I'm hoping that my dinner is prepared for me while we're in here. And who's joining us on the phone?
Hey, it's Brock, Stephen Brock.
First time caller, long time listener.
The VA emergency. Yeah. Hello, can you hear me?
Yeah, first time caller, long time listener.
Oh no, I was at the last one.
I'm just teasing you, Stephen.
Second time caller, long time listener.
I'm sorry, I didn't mean to cut off your intro. I actually do want to introduce you to Ayla as well.
We already met virtually.
Yes.
Yeah, I reached out to him after you sent me the link. So I was like, okay, let me try to find him. So thank you.
Awesome. Are you going to be able to connect?
Yeah, well, I found out today that her school has a contract with my VA location. So we're going to try to see if placement can work.
Oh, I
for
love
one
that.
of her clinicals.
Yes, that's exciting.
Awesome.
Yeah, I'll keep you updated, Ayla.
I love it. Okay.
Thank you.
Well, and I'm actually really proud to say that I've interviewed Kyle and Stephen, and so you can find their profiles on our website as well to learn more about what they do and to hear their podcasts about their unique experiences. Kyle was an outpatient PT that progressed into emergency department PT as well, and Stephen has a really unique position in the VA health system, which is fascinating to me. All right, so Keith, why don't you take it away with your article? I love this article. I reread it today. I think there are so many like mic drop moments in here. And I think just the background when it describes the purpose, that the purpose of the study is to assess the impact of emergency department PT on imaging studies obtained, rates of opioids prescribed, and ED length of stay. Why do you think those things were important to look at?
Well, the opioids is an obvious one. I don't think we need to go into too much detail on that. Length of stay, of course, is always a consideration anytime you add another provider, another person interacting with a patient in ED. Typically, there's a backlog, there's people waiting, and they like to get people through as quickly as possible. And so one of the objections that comes up from providers is physical therapy going to make them stay here longer? So that was a really critical question. And imaging, obviously, we know that the data shows that particularly advanced imaging, but really any sort of imaging can lead to increased downstream cost and arguably quite a bit of unnecessary care. And so if we can reduce imaging, hopefully we can reduce downstream cost and improve people's outcomes.
I love that. I think particularly in our emergency department, when I look at like what is slowing things down, particularly the patients that should be moving fast,
Yeah.
It's unnecessary imaging, right?
Absolutely. And I would argue, I think that one of the big things that led to our reduced length of stay was the fact that fewer of my patients had imaging. And so they were done quicker, not just because I improved their throughput, but because we decided not to do imaging on them. So, that's just an idea I have from looking at the data.
I love that. Does anybody have any other thoughts about the purpose in measuring these tasks or these particular outcomes? Do you measure them in your emergency department?
It's hard to measure, especially when you're starting up a program, because the sample size needs to be large. So, but those are definitely great metrics to measure. But also trying to find a way how to quantify patient outcomes long term is also something that we're trying to measure, but trying to parse out the specifics on how to do that and what's the most logical and feasible way to come up with an outcome measure to track long-term changes and if our interventions are significant.
Yeah, I think that's part of the issue here. When I look at these three things, we have imaging studies obtained, rates of opioids prescribed, and ED length of stay. I don't know how much of that is really that meaningful to the patient, right? Because length of stay obviously meaningful to the patient, but so many patients come into the emergency department expecting both opioids and imaging. So if we're reducing those two things, are we actually increasing patient satisfaction or not? And I think as physical therapists, we know the answer to that our patient satisfaction scores go way up when a patient actually sees a physical therapist in the emergency department. But these two factors, as are discussed in the article, can really kind of affect that balance of patient satisfaction and meeting patient expectations. Keith, what was your sense of that?
Yeah, absolutely. And I think that you're absolutely right that those are the two things that people expect coming in. And so when you violate that expectation, you better have something pretty good to back it up with. So one of the comments, I don't know if I can flip to it quick enough to find it here, but there was a comment in here about
the keyboard.
how physicians are often kind of caught between the,
I don't want it on there. Mine is the white one.
somebody needs to mute. That ED providers may find themselves trapped between conflicting mandates to alleviate pain, maintain patient satisfaction while practicing in accordance with national guidelines. And I think that those can be really challenging things to balance, to balance out. So one of the things that we've got another study that we haven't had really great enrollment in, but as Kyle alluded to, practice or measuring patient outcomes is pretty challenging. We were trying to do some patient reported outcomes and some satisfaction on that. Unfortunately, we weren't able to get a whole lot of data yet, but in spite of the fact that they weren't getting opioids and imaging at the rates that they expected, people had very high satisfaction scores with their physical therapy interaction and ultimately with their ED stay based on the fact that they saw physical therapy. So I think that we've got a long ways to go to show that in our data, but anecdotally, the evidence is there. Those of us in the room, I think, are aware that that is showing up.
Yeah, our most recent pilot program that we did from February, we did for 90 days from February till, I don't know, whatever 90 days from February is. We measured patient satisfaction just on a Likert scale of 0 or 1 to 5, the very dissatisfied or highly satisfied, and I think our average came up to 4.89 out of 5 patient satisfaction. And what really struck me were the patients that I was sure would not be satisfied, like certain that they were going to like mark it really low because I really didn't fix anything. They left with the same problem they came in with. But I think that speaks to how we provide those interventions, Stephen, that you alluded to, like what are our interventions, how are we measuring those, and how do we associate outcomes with that? So Keith, can you speak a little bit to the interventions that you provided in this study? Because it really summarizes them nicely, like what your strategies were.
Yeah, let me see if I can just flip to that really quickly. Really, I start with a motivational interviewing kind of an approach. I very much sit down, ask some open-ended questions, and try to get a sense of who a person is. And that's really kind of my first approach when I see a person. And sorry, I'm still trying to flip to like I need the paper to tell me what I do.
Well,
But
I've got it here, Keith. It says motivational interviewing style to solicit narrative history, red flag screening, movement assessment, and then education regarding the nature of musculoskeletal pain, reassurance for the lack of red flag findings, and discussion of the natural course of musculoskeletal pain, and avoidance of bed rest, and therapeutic interventions based on directional preference testing, gentle manual therapy, and mobilizations.
yeah, perfect.
I know, it's amazing. You did all the right things.
Yeah. So yeah, I think it's really about number one, finding out, doing that really good interview to find out what brought them in, what their symptoms are there any red flags? And so clearly in any primary care setting, or in any setting where we're seeing a person, we need to make sure we're screening for the red flags and make sure there's not something that we're missing. And so for me, that's a really, really big one, is to do a very careful questionnaire to make sure that we're not missing anything important there. From there, it's about finding how their symptoms came on and finding out, those aggravations and eases and things like that, that is there a directional preferences or something we can do. But I think that this is purely my opinion, but I think that my approach of really doing a lot of cognitive reassurance is probably one of the biggest factors in the patient outcomes. And it's feedback that I've gotten from emergency as well as just in the outpatient setting, that ability not just to be able to say that you're okay, but to be able to explain why they're going to be okay, why it is that you. And so this is something that I kind of learned, I think, during my time in EDU about not just doing a red flag screening, for example, but actually telling them what I'm doing while I'm doing it. I didn't used to do that. And so now very often I'll just kind of give a running narrative as I'm going and saying, so, the reason I'm testing your reflexes is because we often find if there's a neurological deficit that the reflexes will be altered. And so a muscle test, I just kind of go through, we're looking for sensation. Is there any changes here? And so as I go through that stuff, and then I say, I've screened you for red flags, I've told them why. When I ask the bowel and bladder questions, the sexual function questions, where I'm explaining why. I say, I know these are kind of weird questions, but I'm asking them for a reason, and here's what I'm looking for. And it's interesting on the red flag questions. If you more clearly explain why you're asking the question and what you're looking for, people will often give you a whole lot more information than a quick yes, no. And so I think that understanding why the purpose of the question and asking it in very clear and unambiguous terms is really, really important. So at that point, it's much easier then to move into an assessment. When you and I talked on our interview a few days ago, Rebecca, we talked about how I very often do some education before I go into my assessment. Because I find that you have somebody in acute pain and jump right into trying to ask them to move, or moving them, or palpating them, or muscle testing them. They're scared, they're not sure what's going on, they're nervous about whether they're okay or not. And if you just start taking over and not giving them any agency in the interaction, they become more guarded, more apprehensive, more nervous about the whole interaction. And what I found was that by giving a little bit of cognitive reassurance, a little bit of education in that early stage of the interaction, at that point it was much easier than to go into a brief assessment as much as we were able to. It's difficult in a hospital bed with monitors attached and all those sorts of things, but doing whatever we could assessment wise, and then moving into manual therapy. Can we get a person moving? And I really think it's more about showing them that it's safe to move, and kind of help guiding them and getting them to start moving actively as quickly as they can. And once they start to see that, then the reassurance really just sort of comes naturally, and they're able to get up and start moving a lot easier. So hopefully that made some sense, but that was kind of a ramble about what my approach is.
I totally agree with you. I always say that the first step is to turn off the car, right? Like if you're going to pump gas into the car, you have to turn off the car first, because otherwise you can't fill it. So you have to I focus on settling, trust building, problem identification. So the question I have for everybody based on what you said is what is your clutch question in your history that you ask your patients? What is the number one question that you never forget to ask those patients? Kyle, do you want to go first?
I took this from either Maitland or McKinsey course when I took it. Was, what do you think is going on? And a lot of times you learn a lot of things by having them answer that question, specifically on how much they actually know about spines and general anatomy, things like that. Sometimes they say, I really have no idea. And then you can kind of, he's talking about the fear and things like that, talk about reassurance and what you think maybe possibly going on and things like that. So I guess that's my go-to question a lot of times is, what do you think is going on?
Anybody else? I just kind of foisted that on Kyle, but does anybody else want to share a question that works well for them to get good information from their patients?
I just jump in on the back of Kyle and say that was almost exactly what I was going to answer. I love that question. And some people look at you and are kind of taken aback by it and say, well, you're supposed to know that, not me. But as I go, that's okay. I just want to see what you're thinking. But I totally agree that you can learn a lot very often from asking that question. If anybody, does anybody else want to comment? That Carlene left a question in the box that I want to try to understand or try to answer. Does anybody else want to answer that, Rebecca's question?
I usually ask people, what do you think has been overlooked? Because patients often they don't come to the emergency department usually because they want to. They come because nobody's listening to them. They come because they don't have access to care. They get to me because they feel like nobody's listening to them. So I will often say, what do you feel like has been overlooked so far? Or what do you think I need to ask you that no one else has asked you?
I like that one. Yeah. For me, it might be a little bit different if they're an acute onset versus a chronic pain. You get somebody that comes in with chronic back pain with a flare that comes in today. I like to ask them, what made you decide to come in today? Because they live with chronic pain. If it's an acute pain question or a person with acute pain, I don't answer that question. But with a chronic pain person, I think you can get a really interesting response from them sometimes that way.
Yeah, what's different than a previous occurrence of this episode? What's different today than the last time you experienced these symptoms?
I love those. Anybody else? All right, I'm going to leave you to field that question, Keith.
Okay. So Carlene, you can see us in the chat box when narrating exam. How are you handling abnormal components? So, I think that we're obligated to be honest with the person as we go through. I try really hard not to, react and go, oh my God. I've heard so many stories of people, patients in a medical setting where a provider reacts in a really sort of shocked sort of a way when they find something bad. And I think we need to be really aware of that. But I also think it's like, okay, this is really interesting to see that, your reflex is diminished here. That may mean that we have some decreased nerve function, and this is something that we need to look into a little bit further. Or, gosh, this muscle is really weak when I muscle test it. Do you feel like that's because of pain and you're not able to do it, or you actually not have any strength there? If there's a loss of sensation, loss of reflex, I'm trying to think of what some of the other abnormal findings might be. I'm going to give them a very sort of glossy big picture comment about what that might mean. But clearly, if we find some of these kind of things, we're going to need to do a little further assessment. I'm going to try really hard to always answer in a fairly vague and general way in the first place, because we know that a lot of times those red flag questions and screening things really aren't very accurate in identifying anything. So it really just opens us up to ask more questions and do more testing in those situations. Carlene, I'm not sure if that answers your question or not. It's a, if you find somebody with a really concerning finding, we need to investigate further. But we also need to inform them along the way of what's going on. I'd love to hear what you have to say about that, Carlene.
Yeah, I was just thinking, because I kind of do the same thing as I'm going along, but I give it more of a trailing narrative, just because when I do find something that's abnormal, and thinking more when there's hyperreflexia, and other unusual clunks and things that you're like, oh no, and then then you start digging for a pattern, and keeping them busy so they're not, I don't want them to get worried, because oftentimes it ends up being nothing, or it's not something that necessarily is going to get further worked up in the ED, and you need to have that patient follow up with another provider outside of the ED, but trying to stress to them that let's not let this go, and no, please don't go to PT first. Let's get you to so and so. But yeah, I was just curious how, when you're doing the play-by-play, so that you're not giving off that vibe that, oh wait, why his tone just changed, what's going on?
Yeah, and honestly, I'd say I haven't had that happen a lot of times, and so you have way more experience than I do in that setting, but I've certainly had it happen a few times. And yeah, it's about saying, this could be something really serious. It may be nothing, but it's something that we definitely need to investigate further. And so let's do that. Let's get it answered as quickly as we can. So it can be hard to not hide your concern, I think, but it's definitely something we need to be aware of.
I definitely have a face I make at the curtain. My face. Ooh. I had a patient recently, Carlene, this reminds me of who the physician said, something's not quite right, but mostly it looks fine. And if you weren't here, then I would just discharge this patient, but maybe take a look and see what you think. I did the most thorough neuro exam I have ever done in my life. And I agree, it was just not quite right, but really patient was independent functional. There weren't enough red flags that warranted any other emergent workup. The patient had an appointment scheduled with a neurologist and a neuro PT within the next 5 days, but it just bothered me and I couldn't put my finger on it. And so I think in a case like that, all I did was really give extensive return precautions. These are the things, if these things change or you notice this, this, and this, then I want you to come back. And in this case, the patient did come back within 12 hours because I think her clinical picture was evolving. And I had said, if you experience any bowel incontinence, as one example of several things I was concerned about for her, please come back to the emergency department. And she did. And she ended up getting like basically head to toe MRI at that point because her symptoms had evolved so very quickly. And I mean, the MS burden that was on that MRI was tremendous. And I think she had just been functioning, but was like at that tipping point where it wasn't like just balance was just a little bit off, and like what just wasn't quite right. And it was one of those things that even putting together all of the pieces, it just didn't feel right. And so I think in that case, when we have this gut feeling that we can't really back up, I think that's a hard balance too, because you don't want to scare people, because part of our job, like Keith said, is to not scare people. But in that case, I was glad that I had at least taken that time to like really be thorough with the return precautions for that patient.
I would say pretty similarly. I like to be very clear with my communication with exactly where my reasoning is at. And I tell them, these are the things that I'm seeing that are yellow flags or the not quite right. But also saying, like, I pose the red flags more so as hypotheticals. And sometimes it's an educational, just like, look out for this. But then there have been other times where as I'm going through red flags, suddenly more information gets added to the subjective, or they're like, oh, that has happened, or I have been having, issues with, I don't know, numbness that I didn't mention, or so in those situations, I pose it again as a hypothetical, so that it's not like I am very worried because you will get worse. It's more so they have kind of more trained eyes almost to look at themselves with.
Yeah, totally agree. Just in terms of, you turn over
Trust your gut.
one rock and ooh, that's not right. And then all of a sudden, yeah, more information starts coming out, and masks have helped over the last few years, just kind of contain some of that. Oh crap. And then it always seems to be somebody new that you're working with, and okay, first timer here, and I'm gonna drop bad news on that doc. That yeah. Sorry to tell you this. I know you wanted this to be a simple discharge, but
I love that. Keith, I'm going to turn us towards the results of your study. Can you share the results? And just to clarify for those that may not know, you were the only physical therapist involved here, right? So you completed all of the examination, evaluation, and intervention on your own.
Correct. Yeah, the basic results on the length of stay was that the average person who saw physical therapy was 4 hours versus 6.2 hours for those that didn't. There was a significant reduction in imaging, at 38% with physical therapy versus 51%, but most of that was X-ray. I don't think the advanced imaging was that much different, although there was a difference in this low back pain subgroup that was higher. I don't remember if we broke down on that one, advanced imaging versus X-ray or not. But in the subgrouping of low back pain, it was a very small number, but we had 25% of the people that I saw with imaging versus 57% without. And physicians are just not very good at symptom modification, and so the best thing they're good at is making the symptoms worse. So when a person's in pain, they have a tendency to pretty quickly jump to imaging, I found. And as we comment on in the paper, one of the things that I pushed really hard pretty early, and I had a bunch of providers that trusted me, was I want to see them early, not later. And I know that Kyle, your work with Howard, the papers that I've read talk about PT coming in a little bit later, and I think that that's one of the things that I really want to see us do a better job of getting in as early as possible, because I was constantly talking to providers about I don't want them after they've been here for 4 hours and after they've had an MRI and after they've had, at that point they're so wound up, it's really hard to get them settled back down. So we really pushed on to getting them in early. And if I could modify their symptoms and get them moving better, that really reassured the physicians to not do so much of the advanced imaging. And then a couple of other significant findings, obviously opioid. I think that in hospital, there was only 18% with opioids for the group that I saw versus 33% without. that didn't see me that were prescribed opioids. On discharge, there wasn't really any difference, but the number was very small. It was like less than 5%, I think. I don't remember what the outpatient discharge. I don't see the number here right now. Anyway, it was pretty small. And interesting was benzos. The people that I saw only received about 17% received benzos, and 92% that I didn't see. That number shocks me. I actually went back to the primary author and asked him to double check that number because I'm kind of shocked by it. But that's what we published was 17% versus 92% reduction in benzos. So I think that was a pretty significant one, and gabapentin as well. Not a huge number of people getting it there, but so
do you think
yeah,
that speaks to kind of the psychosocial components of pain?
but I do. That's my, you know me well, that's my bias, that I feel like that's a strength of mine, is to be able to go in there and sit down and talk to somebody and calm them down. And that's one of the things that having a good communication style, motivational interviewing style of talking to people, you can really kind of turn things back around, find out what they're thinking. Like Kyle said, what is it that you're worried about? What do you think is going on? And be able to turn around and talk about those things. What are you worried about? What are you afraid of? And then let's talk about those things. And here's why I think it is or isn't that. I've done this exam, I've done this movement, and we've done this, asked these questions, and so we're really confidently able to rule those things out. And for those people particularly with nonspecific back pain, I think that a really good psychosocial approach on top of a good biological physical exam can go a really long ways towards reducing anxiety, which corresponds to a significant reduction in pain typically.
Was there anything in the results besides that really surprised you?
I think the big one for me was the benzos. That was the one that really jumped out at me. One of the worst things I wish we could have tracked that we didn't report in this study was how many people actually who received a prescription for opioids on discharge actually filled it or didn't, refills. I know we looked at some of our other data, we looked at refills, but we haven't published that yet. The people that get or to physical therapy have a significant reduction in refills on opioids, but we didn't measure that in this paper. I think that was the big one. I actually thought probably the biggest thing that surprised me actually was I thought that my interactions would make the visit longer. I think that was the biggest one that surprised me, was that because sometimes I drive the nurses crazy, because sometimes I'm in there for an hour with somebody if they're a really complex patient. I've had people that in the middle of an exam got stuck on the bed, with their butt up in the air or something like that. It's like, okay, it's going to take us a half an hour to get out of this position. So that was probably the biggest surprise to me, was that actually we had shorter length of stay than the people who didn't see ED, didn't see physical therapy.
All right, I'm going to ask you to talk about the limitations of this study, because this is a pretty great study, right? Like, this is something that I feel like as a physical therapist in an emergency department, or somebody who was trying to start a PT program in the emergency department, like I could take this to my administration and say, hey, look at this, this is amazing. And we even had a case recently where we asked for imaging on a patient, and one of the providers filled out a safety incident because we asked for unnecessary imaging. Like, talk about like turning it around the other direction. And in our case, it was just a difference in interpretation of the auto ankle rules, right? Where sometimes we do increase imaging, sometimes we decrease it, just depending on what the patient's needs are. So the limitations in this study, like if you were an administrator, what would you come back with? I'm
not really sure that our sample of our sorry, I'm not a researcher. The language doesn't roll off my tongue, but the control group, sorry, I'm not sure that our control group was really robust. And, that's probably one of the biggest concerns to me. We had a pretty small N to begin with. Like I said, this was early in my, this was the first 18 months that I was in emergency. And early on, the doctors really didn't know what to do with me, nor need them early on. And so our numbers are small. And they just kind of took a convenient sample of people that came in at the same time of day on days that I wasn't there, but how well did we match them? I think they tried really hard to match, but I'm concerned about that. You know, there's one physical therapist who's there. It's just one person. Can it be reproduced with somebody else? I think it's a concern. Maybe, you know, maybe there's just something unique about that person, or, you know, something about that. What were some of the other limitations? So single site, single physical therapist, comprehensive.
One that I thought was interesting that they mentioned was they didn't look at whether or not the imaging was appropriate or inappropriate.
Yeah. That how do we determine, where's that at? We know that many patients with musculoskeletal complaints receive unnecessary imaging. However, only overall rates were compared in the study, and no conclusions can be made about whether PT reduces unnecessary. We just know that it reduced imaging, but we don't know if it was unnecessary or not. And I think that one of the arguments that can be made is your numbers look better because we already screened out the bad ones and we didn't send them to you. You know, so I think that's the unspoken right there, is that we just gave you the easy ones. I would argue from being on the ground that that's not the case, but I think that that's definitely an argument that could be made. That and I'd love to hear what each of you think about that, Kyle and Rebecca and Carlene. That Alex, I don't know you. I'm sorry. I probably should, but I don't know you. But I'd love to hear what you guys think about that, because I think that that's that's an argument that could be made, that, well, once the physician's seen him and screened him and, you know, already taken the bad ones, then we're giving you the easy ones. So that's a limitation that can be argued.
I was going to add, I was on a focus group a couple weeks ago with an ED physician, some other PTs, and one of the things the physician talked about was that there are no RCTs to prove that physical therapy is effective, which he was probably right on. But at the same time, I'm thinking like a control trial within the emergency department. The control and the emergency department are two things I feel like don't really go together, just because there's so many variables throughout the day. Yeah. So at some point, probably we will get better evidence, but at the same time, like, I think this evidence is pretty robust in itself. So I don't know what else we can do about that.
I'm curious about the logistics of gathering data. For example, with the if you were to address some of the limitations, especially the one that stuck with me was like, well, you got the good patients, or with the current EMR systems in place and how easy it is to generate reports looking forward, is it possible to say, okay, every single patient that comes through the ED with these set of, you know, presenting issues gets included into the study? I mean, it would make for a massive control group, I'm sure, but could that then give the perspective of, well, what happens down the line with those that present versus, you know, are addressed on the acute side versus are admitted and then pursue perhaps surgical care and so forth?
I think that was one of the limitations mentioned, was like that lack of longitudinal follow-up. So are we making an impact in this one visit? I think the data would say yes, but it is hard to know like what's happening down the line. I think you raise a really good point with that.
So yeah, and I actually have, that was just going to bring that up. I have an interesting bit of unpublished data, but we had a abstract that we presented at I forget my acronyms. Where did we present this one at? SAM, I think, where we looked at, sorry, I have to look at this on the computer, 112 patients, again, a pretty small group, atraumatic low back pain, 56 PT, 56 non-PT, and bottom line, fewer imaging, shorter length of stay, advanced imaging, but bounce back is what we were looking at. And so So fewer PT patients returned to the ED at 1 year. So we looked at 3 days, 30 days, and 1 year. And so of this small group, 56 patients of PT versus non-PT, at 3 days, we had 0 of mine versus 5.4% of the physicians. At 30 days, we had 5.4% of mine versus 12.5% of the physicians. And at 1 year, this is the one I'm the most proud of, 19.6% for me versus 39.3% for physicians. So it's a pretty small N, but 20% versus 40%. So seeing PT significantly reduce the bounce back in this small group of patients. And so, hopefully we can get better data and publish more of this kind of results to kind of answer that question. We also, I kind of alluded earlier to trying to do some, we used PROMIS in Utah at the U for our functional outcomes. And we were trying really hard to collect data on functional outcomes. It was really hard to get people to be excited. They didn't want to do the study. Excuse me, it's really hard when somebody's in emergency for back pain they don't want to sit there and answer a whole bunch of questions. And so we had a pretty hard time recruiting people into it, and recruiting over a long period of time, we had a really small group of people. So there's a paper that we've just gotten accepted for publish that looks at that, but unfortunately the numbers are pretty small trying to look at functional outcomes.
All right, Keith, any like major take homes you want to share? Anything else you want to discuss before people can just ask you some questions?
I think for me, it's just, I hope that we continue to come back with more and more data. I know several in this group are working on it to just validate that we belong there and that we are truly making a difference. For anybody who's interested, say Isla, just such an amazing setting to work in. I think that my bias is really strong. You have to have really good clinical assessment skills, but you have to have good patient-centered skills as well. And my take home is that that patient-centered, very kind of a psychologically informed approach of sitting down and getting to know a person and giving that cognitive reassurance is such a powerful piece of managing the non-specific pain. And I think it's really powerful with specific orthopedic injuries, musculoskeletal injuries as well. But just the value of putting that psychosocial piece along with a physical exam and making sure that you're managing a whole person instead of just managing the knee or the back, for example.
Who has questions for Keith? I have one.
Okay.
How much time did it add to your workflow to do all the data collection on this and to be part of this?
So in this particular paper, not a lot. We have RAs in our emergency that do data collection. So the biggest thing that this did for me was made me oftentimes go find the RA and say, hey, can you go see, room 7, because I'm going to go see them and I want to try to get them in the study. So I didn't have to do the data collection or the number crunching. I saw the patients and I helped with the writing of the document, but I didn't do the dirty work of the research on this paper. So it wasn't that hard. It's hard to co-write. It's not something that I'm good at. Writing with 3 other people, and I had a couple of pretty cool co-authors on the paper with me. So it's a little bit intimidating to write alongside people like Jake Magel and Julie Fritz and Troy that are our physician that's at the bottom of the paper. He's just a fantastic physician and has published quite a bit as well. So it was a lot of fun to work with him, but for a first research paper for me, there was some intimidation there, but not a lot of extra time.
I actually had a great conversation with Dr. Magel the other day. I was hoping he would be able to join us today, but he was not able to do that. I mean,
Yeah.
what an interesting job to just do research like that all the time.
It's pretty cool. Yeah, he's got some great projects going right now. So I'm lucky to be able to just walk up the street and have coffee with people like that on a regular basis. So it's pretty cool.
I asked if he'd take me for fellowship hours. He says he doesn't take fellows.
Yeah.
Who else has questions? I don't think it's that often where you actually get to like ask an author questions about their paper. So I think this is incredible.
Yeah. I have a question, Keith.
Yeah.
Other than you voicing a desire to, maybe not get thrown into the study so early upon you entering that setting, were there any other things you would want to change about how the study was set up, or anything about the study that you would do differently for round 2, other than maybe the sample size and, the length of time you were practicing before starting to collect data?
It's an interesting question. I hadn't really thought about that. I want to look at how much difference does it make for the person. This paper is about how many, and Rebecca brought this up earlier in the discussion, but this is more about, do I get in the way of the doctor? And and unnecessary imaging and opioids are going to have some downstream effect for people. But what I really want to be focusing on is, did I help the person today? And so that's really the stuff that I think is a little bit harder to measure. But those are the things that I would really be interested in studying more next time. Of course, the bigger sample size and things like that, but that would be the big one for me. It's so hard to decide who is and isn't appropriate to be seen by who. Is imaging necessary or not? There's so much. If you look at some of the research on just advanced imaging in an emergency department by physician, you'll see that from physician to physician within the same ED, there's huge variability on practice. And so, having it really depends on what physicians are on call, are working the night that I'm working. I would show up and look at the board some days and go, oh, so-and-so's here. I'm not going to see anybody today because, this physician won't use me. Or other days I'd walk in and say, oh, there's a good group of people here today. It's going to be a busy day. So, I think that that one of the things that's such a critical skill for a physical therapist in emergency to have is to really develop those relationships back with the providers. And again, when Rebecca and I were talking the other day, that's one of the things that I mentioned, that I feel like one of my biggest wins was just really having strong relationship with providers, because once they trust you and once they start to understand a little bit more about what you can do, I mean, some of them would lean pretty heavily on me, and I've had physicians call me in and ask me to see all kinds of stuff that wasn't necessarily musculoskeletal, but just based on my more kind of whole person approach. But it really reflected a trust that they had in me. So that relationship building with the physicians is just a critical piece of it, I think.
My question kind of plays
That's
along
incredible.
with that. Specifically, have you talked to any of your colleagues since you haven't been working there to see how it's been going? And can you get a study of how terrible their low back pain treatment was without you there?
I hadn't thought about that last piece of it, Kyle, but I'd love to do that, and I might go talk to Troy about that. I have talked to a lot of my colleagues, and it's I sound like I'm patting myself on the back, and I don't mean it that way, but they miss me. I was for the first year, as time goes on, you know, that you can kind of get forgotten about a little bit. But man, that first year I'd be giving texts and emails all the time. I said, man, I wish, you know, wish you were here. Where are you? I miss you. You know, I got a patient right now. And I'd be, they'd be leaving me voicemails on my phone. You know, Keith, I've got, you know, a patient here. I need you to see as soon as you can. So yeah, they really missed having therapy there. And, you know, once they were used to it and it wasn't, and that's some of the things, some of the early papers, and forgive me, because I know at least Carlene was involved in some of the papers, and I can't remember who wrote which paper, but you know, the idea that when physical therapists first started working in EDs, that the doctors didn't know what to do with them, and after they'd been there for a year, you know, they didn't know what to do without him. They couldn't figure out how they'd gotten along without him. And Carlene, I think you were on one author on one of those papers, but that's been a really definite thing that I've seen the physicians saying, when are you coming back? Once I told some of them that it was in the works that I was coming back, I'm getting texts every 2 or 3 days, you know, when is it, you know, when are you coming back, you know, hurry up, we need you. So yeah, that's been really just kind of personally rewarding for me. But I think it'd be a really interesting question to talk to him about, you know, what have you been doing with back pain, and can we take a look at some of those numbers? That'd be a fun thing to look at.
Any other questions?
I have a question. It could actually go with either one, anybody, but as well, since you've been out and you've noticed a difference, have they considered adding an additional PT in the ED as well?
So for me specifically, what happened with me was I was actually an employee of the outpatient physical therapy department. I've told the story other places, but just really quickly, it's okay. I was seeing an ED provider as a patient with back pain, and was able to help them. And so they said, can you, you know, I hate seeing back pain. Can you come work in ED, because you know, I need you. And so I have a supervisor who is a visionary person and thinks big picture and believes in, you know, physical therapists doing amazing things. And so she was willing to continue to pay my salary and loan me to emergency. When COVID happened, I got pulled back in because I wasn't an employee of the emergency department, and they kicked out everybody that wasn't, you know, 100% essential. And certainly in the first 9 months, you know, everybody who works in EDs knows that the census dropped way down. A lot of people weren't coming in. And so it was probably wouldn't have been worth my time being there. But the reason it's been hard going back was all about budget, because my outpatient physical therapy department, they shut us down for 3 months. We didn't see any patients, but our university continued to pay us, which I was incredibly grateful for. But that put a big old hole in their budget. And so they're like, no, we can't afford to do this. We got to earn our money back that we lost over there. And the same thing in emergency. They said, we'd love to have you back, but we're cutting like crazy right now ourselves. And so it was a budget issue for everybody. And if you can think big picture, you know, I think I can save the hospital money, not cost them money, but bottom line, I got 2 department heads that are looking at balancing a budget. And so everybody was saying, we want you here, but we want somebody else to pay for it. So ironically, while I was gone, just in the last, I think 6 months, the inpatient therapy department has started sending OT down. And Rebecca and I have talked a little bit about this because I know she has OT in her emergency. And so going back in, it's going to be interesting for me to figure out how to work with them, figure out what they do, what I do, you know, see if we step on each other's toes. I was talking to one of the ED physicians the other day, and he was asking me, do you think there's going to like be any turf wars or anything when you go back? So I hope not. You know, I don't really know. So yeah, I think everybody wanted me back. It was just a matter of budget and who was going to pay for it. And finally, my awesome supervisor said, you know what, go do it. And she's, there's a grant in the works at Northwestern, and Dr. Kim is trying to put together a multi-site study, which I'm really excited to, hopefully that'll be funded, where to my knowledge is the first multi-site ED physical therapy project there's going to be. So it's going to be really fun to be a part of that, assuming it gets funded next year.
I don't want to speak for everyone on here, but I always tell people that aren't in the ED or starting programs, I think the most important thing for me and our success is basically a good team. We see patients 365 days a year, but to have the ability for more than one person to kind of go down there and cover the hours that I'm not there, or if it gets really busy, to have somebody else that's there that can help you if you do need help. I think that's the most important thing that, for me personally, that makes our group successful.
I agree. I don't think it should be a service that's just provided when one person is there and one or not. Otherwise, we're doing a disservice to a huge group of patients.
And yeah, and you know, that was when I was at the end of my first phase. I was talking to the ED chief of staff and asking her about, you know, how she felt it was going and what, and she's like, I want PT here 24/7. They loved it so much that, you know, that they felt it was a disservice to not have it. So that was a huge compliment to, you know, to hear that. And I think that the providers that get it and that understand what we can do, you know, they really, you know, how come you're not here on, you know, nights and weekends and vacation, you know, what are you doing taking a vacation? I said, you know, I'm one person, I can't be here all the time. Kyle's the same situation for the most part. I think you're kind of solo, aren't you, Kyle? So yeah, you know, you can't be there all the time.
All right, well, I want to be respectful of everybody's time, so we're going to wrap up. I just have a few announcements of different opportunities that are available. We will have a final quarter journal club. It will be geriatrics based for emergency department and geriatrics practice. I had some requests for that specifically. There is a health symposium. I'm going to drop links in the chat for some of these events that is coming up here on September 16th. This is a completely virtual event. It is a virtual symposium about the intersection of public health and physical therapist practice, which by connecting ideas places people through technology and innovation to advance health equity. So it's going to be a really cool symposium period. It is $10 to register. And if you look at some of the names that are on there as presenting, I think you'll be kind of blown away by it's people from all over the country. My colleague, Dr. Mark Magdaleno, and I are presenting a platform presentation on our pilot program from direct triage to physical therapists rather than PAs or NPs in the emergency department. And APTA Colorado has an event coming up on September 30th and October 1st, which there is a pre-con course, a one-day pre-con course about wilderness physical therapy and like how we can get involved in that. And it's hands-on and outside in the mountains of Breckenridge. So I would highly recommend that. It's a really good price for that. And then if you stay for the whole conference, we are presenting 3 hours on emergency department and the older adult and how to make that a better experience for the older adult population in the emergency department. And then coming up in November, Carlene, I'm going to have you speak to this, the 4th annual EPT conference. I'm going to drop that link here too. And that's going to be on November 11th and 13th at the University of South Carolina. Carlene, do you have details you want to share about that?
Not until I talk with Ty yet, but
Great.
yes,
But it's coming.
Several local speakers who have already offered to present in South Carolina, and we plan to do this partially recorded so that we can share it afterwards for people who can't do the travel, but looking forward to meeting together in person, that's for sure.
Definitely. And if you have not been to this conference, Carlene and Ty do a great job. It's an amazing experience. You get to network with PTs in emergency settings from all over the world. So definitely don't miss that. And if you have not signed up for our newsletter, please do. We are sending out discount codes for things like our continuing education webinars and as well as different resources for you to help you in your practice, because my goal is for emergency department physical therapy to be well known and well practiced. So I appreciate you all being here tonight. And if you have anything I can do to help you, please feel free to reach out. And thank you for coming.
Awesome. Thank you.
Thank you.
Thank you.
Thank you all.